Okay, let me just get one thing. Okay. Okay, can everybody see my screen?
Yes, we are able to see your screen.
Okay, so as I said, I am the director of global ultrasound in the Department of Emergency Medicine at Massachusetts General Hospital and Harvard Medical School. It is great to be with you all today. We'll be talking about basic point of care echo. So throughout the lecture, feel free to stop me at any point. Faith, if you could look at the chat and let me know if there are questions that I can answer as I'm giving the lecture, I would be happy to. And hopefully we will also have time at the end of the lecture to go through some questions as well. Okay, great. So let's start. So the goals of the lecture, so we're just going to talk about three basic things here, or they're going to be grouped into three basic things. We'll be talking about basic image acquisition. We'll then talk about what normal, cardiac ultrasound looks like, what a normal heart on ultrasound looks like. Then we're going to go into pathology, or what we like to call the 3 E's of cardiac ultrasound. So how do you do this first? So first of all, you have to know what your tool are. So this is a phased array, or it's also called a cardiac probe. It's a low frequency probe. So that means it's able to see things that are deeper, clearer, things like the heart. As you can see, it has a small footprint here. So that means it's able to go in between ribs, which will be helpful as you want to view the heart, which is kind of enclosed within the rib cage. Now, when you're doing this examination, we want the patient to be lying flat on their back or supine. And for some of the views, it will be helpful if the patient is laying on their left side. And we're going to discuss that in general. Of course, we want to be, this is an exam where we are looking at the heart. So we want to make sure that the patient feels comfortable when they are doing this examination, because you will have to expose the patient. There is 4 basic views for the cardiac ultrasound. The first is the parasternal long axis view. The second is the parasternal short axis view. Then we have the apical 4 chamber, and then the subxiphoid view. So this is just a schematic. These 3 stars here show the 4 different positions in which we are going to be doing this examination. So think about the heart. It sits obliquely within the chest wall, right? So when we're doing this examination, we are going to be using that to help guide as we move and as we orient ourselves with the probe. We are going to have this schematic here, throughout the slides to help orient us. This big star here just shows where that parasternal view is going to be obtained. This star here is where the apical view is going to be obtained, and this is the subxiphoid position. So this up here, this is the base of the heart. This is the apex of the heart. So let's start with the parasternal long axis view. So again, cardiac probe. We want the probe marker to be pointing towards the patient's left hip. So I know in some orientations, some people say right shoulder, but we're just going to do the EM way. And the EM way here is going to be pointing towards the patient's left hip. Now, the position, we want to go in that, 2nd to 4th kind of parasternal space. So for men, it's going to be around that 4th parasternal line. We know when we are doing this, something I like to tell learners is that you might not get it on the first view, but it's always good to remember that sometimes you can move one probe, one rib space up or one rib space down. So again, this is our personal long axis view. We have our map here. This star is telling us where the position in which we are placing the probe. Over here, we have the ultrasound still image, and down here we have this anatomical view. Let's start with the anatomical view first. For this view, the personal long axis view, the first thing that you're going to be seeing here is the right ventricle, then the septum. After that, you will be seeing the left ventricle, the outflow tract with the aortic valve here. Then we're also able to appreciate the mitral valve and the left atrium. So this is just on the anatomical view. When we look at what our ultrasound image is going to look like, this is just a still scan here. Right, so this is called the right ventricular outflow tract, or just the right ventricle for our purposes. This is the left ventricular outflow tract. We can appreciate a little bit of the aortic valve here. This is the septum, okay? The mitral valve, left atrium, and this is the left ventricle. We can also appreciate the pericardium, and this is going to be important as we progress. So this is what a picture, like a video or a scan looks like. Again, the first thing that we're seeing here at the very top here, this is the right ventricle. We see the septum. We see the outflow tract here, the mitral valve, and this is the left ventricle. We also see the pericardium. Down here, there's this hypoechoic or anechoic circular structure. That is the descending aorta. So when you get this view, you want to always be able to appreciate the descending aorta, because that's going to be important when we're looking for any type of fluid around the heart. Now, this view, this personal long axis view, it's a really good view just to get a good sense of what the heart function is like. And when I say heart function, I mean like about the squeeze, right? The ejection fraction. So when we look at this left ventricle here, we see it's beating vigorously. I would say the left ventricular function is good. I usually look at the walls here. Something to also help you with LV, with your ejection fraction is look at the mitral valve. Assuming the patient has no mitral valve or valve pathology, you have to look at how well is this, leaflet here touching the septum. If it's touching the septum, then it's most likely good EF, right? Or ejection fraction. Now, on this view, we're able to appreciate the right ventricle, the outflow tract, and the left atrium. They should all be about the same size. So we say they should all be a third, and a third. You can imagine if one is bigger than the other, then something is wrong, or something might be very wrong. So if this looks bigger, it could be a sign of some heart strain, If this is bigger here, it can be a sign of aortic aneurysm, or maybe a dilatation caused from some kind of pathology. If the left atrium is bigger, it could be a sign of like AFib or left heart failure. So I like to make sure that, for a normal heart, that these are the same size and that the LV function looks good. Any questions so far? Please feel free to stop me at any point. And Faith, let me know from the chat. We're going to move on to the parasternal short axis view. So remember, we are in that kind of fourth parasternal space. Initially, the probe marker was pointing towards the patient's left hip. For this view, we're just going to turn 90 degrees or rotate 90 degrees towards the patient's right hip. This is going to allow us to see the heart in cross section. Again, this is our schematic that we have. This is our map that is telling us that we are still in the same position. We just turned the probe 90 degrees. This is our anatomical view. Again, it's like you are cutting the heart in cross section. With this view, we are able to appreciate a couple things. So we're able to see the right ventricle here, this cavity. This is the septum. This is the left ventricle. When we have this view, you want to make sure that you are at the level of the papillary muscles, which is what we can appreciate here. Now, this is a still image of what the ultrasound scan would look like. Again, we see the right ventricle, we see the septum, left ventricles, and this is the papillary muscles here. So this is what our ultrasound scan looks like. Again, we're seeing part of the right ventricle. We see the septum, left ventricle, and the papillaries. Now, this is a very good view, again, to look at, left ventricular function. What I like to tell our learners, if you put a pencil or a pen in the middle of this screen, we want to make sure that all of the walls are going, like all of the walls of the left ventricles are going concentrically into the middle of that circle. That's how I determine ejection fraction, as we see all the walls here as squeezing. This is a good view that the cardiologists use when they are trying to look for any regional wall motion abnormalities, and we do that in the ED as well. Again, it's a good view to look at ejection fraction when there's any type of right heart strain, whether it is acute or chronic. The septum here is going to bow out. So if there's any sign of right heart strain, this will not look like a circle. This will actually look flat. We will discuss that more. Then we also have the pericardium here that is bright, right? So if there's any fluid around the heart, we will appreciate it here. Moving along, we're going to go to the apical 4-chamber view. So with this view, I will tell you it's a view that you have to practice a little bit more, because you want to, it's a view that can be challenging initially, but everything takes practice, right? With this view, you are going to go for men, you are going to go inferior and lateral to the nipple. And for women, you are going to go in that inframammary crease. So remember, like, you just want to let the patient know. Probe marker is going to point towards the patient's right. Sometimes, to make this view better, sometimes I will ask the patient to lay on their left side, or what we call the lateral decubitus position. Again, our schematic and map here. So this is where we are here. We are at this point here for this apical 4-chamber view. We'll start with our anatomical view. So on the right here, we see the right side of the heart. So we see the right ventricle, we see the tricuspid valve, we see the right atrium. We have the septum here, left ventricle, mitral valve, and the left atrium. This is what our ultrasound is going to look like. Again, right ventricle, septum, tricuspid valve, right atrium. Left ventricle, mitral valve, left atrium. Again, this is the apex of the heart here. This is what our ultrasound scan looks like. So again, I'll point things out. This is the right side of the heart. This is the left side of the heart. We see the right atrium, tricuspid valve, right ventricle. We see the septum as well. We can also appreciate the left ventricle, mitral valve, left atrium, and down here is that descending aorta. So we know that we are on the left side. Now, how do you differentiate the right ventricle from the left ventricle? A couple things. If we look at this leaflet here of the tricuspid valve, we'd say it's more apically displaced. So it's more towards the apex compared to the mitral valve, okay? Inside the right ventricle, there's a lot of trabeculations. We have this moderator band that goes across. That's only found in the right ventricle. We can also look at the squeeze. The right ventricle, the way it squeezes is longitudinally. It goes up and then down. The left ventricle, it goes inwards and outwards. Again, those are just some ways that you can use to differentiate, because sometimes maybe they flip the probe. And you imagine if you flip the probe, then you can think, oh, is the right ventricle big? What am I seeing? So again, the tricuspid valve is more apically displaced. We have the moderator band in the right ventricle. The squeeze for the right side of the heart is more longitudinal, up and down. The squeeze for the left side is more inwards and then outwards. Okay. Now, for a normal heart, the right ventricle should be,
Sorry to interrupt.
Yes.
Can you use a pointer, please?
Let me see if I can use a pointer. I will try. I'm not sure. Let me see. Okay. Let me see if I can annotate. Spotlight. Okay. Is this helpful? Can you see?
Yes, it is. It
okay,
is.
Great.
Yeah, thank you.
Of course. So this is, again, the septum. This is the right side of the heart. This is the left side of the heart. So the way to differentiate, let me just move this here, sorry. We have the descending aorta, which is going to be beside the left heart, right? This is the mitral valve. No, I'm sorry, this is the tricuspid valve. On the right side, the tricuspid valve is more apically displaced. Look at this here. We see how it's more towards the apex.
For prescription. Yeah. I've never seen that before. Only the first day that you have been there.
Hello? Okay. So
Sorry about that.
no problem. So the tricuspid valve is more apically displaced compared to the mitral valve. The right ventricle has the moderator band that goes across. That is only on the right side of the heart. The moderator band is just a trabeculation that crosses across the right ventricle. And then the squeeze of the right side is more up and down or longitudinal, and the squeeze of the left side is more inward and outward. Okay. Now, the right ventricle should be less than the size of the left ventricle. Upper limit of normal is 1:1. Okay, so it should be about 2/3 the size of the left ventricle, but at most 1:1. When the right side is bigger than the left, then we're concerned for pathology, and we're going to go into that soon. Our next view is the subxiphoid view. So when we're doing this view, we're going to go in that xiphoid process. It's almost like when you're trying to scoop ice cream, it can be a little bit uncomfortable for the patient, but you shouldn't be applying a lot of pressure. But I just let the patient know this might be a bit uncomfortable. Let me know if you have any pain. And then the probe marker is going to point towards the patient's right side. So the only time the probe marker is going to point towards the patient's left side is when we're doing the parasternal long axis view. Again, this is our map here, tells us where we are. This is the subxiphoid area. This is our anatomical view. We see in that subxiphoid view, the liver is the first thing that you're going to see. The liver serves as an acoustic window for you to appreciate the heart. So the first thing you're going to hit first is going to be the liver. Then we're going to see the right side of the heart, the right ventricle, tricuspid valve, right atrium, septum, left ventricle, mitral valve, left atrium. And this is what our ultrasound scan is going to look like. So this is the liver here, right ventricle, tricuspid valve, right atrium, septum, left ventricle, mitral valve, left atrium. Again, this is our scan. First thing that we're seeing here is the liver. So without anybody telling me what view this is, I can already know this is the subxiphoid view, because the first thing I am seeing anteriorly is the liver. Again, we can appreciate the right ventricle, septum here, left ventricle, mitral valve, left atrium, and then we can see parts of the tricuspid valve and the right atrium. This is a really good view for you to just appreciate if there's any abnormality around the heart. As we can see, this heart might have maybe a very trace pericardial effusion. There's some a hypoechoic echogenicity that comes like around it. So if there's any fluid around the heart, you will appreciate it there. Trace pericardial effusion is normal. You know, we can also appreciate just the function of the heart here. Again, seeing how the squeeze is and seeing, you know, what the right side of the heart looks like compared to the left side. So in ultrasound scans, one view is no view. If I'm going to do a cardiac ultrasound scan, we want to get all of these four views, or at least you should at least have 2 views. One view is not enough. So we are going to be moving on into the 3 basic questions, the 3 E's. And what are the 3 E's? So we've moved on now from normal, and now we are going to look at abnormal or pathology. The 3 E's that you want to ask when you're doing a cardiac ultrasound scan. Is there an effusion? What is the ejection fraction? And what about equality? And equality here refers to the right ventricle size compared to the left ventricle. You know, when patients come in with several things, let's say cardiac arrest, shortness of breath, chest pain, syncope, unexplained hypotension. These are the questions that we want to answer when we're doing a cardiac ultrasound scan. Now, all of those individuals should be getting a cardiac ultrasound scan. And when we're doing that, we want to ask, is there a pericardial effusion? Is that why they are short of breath? Is that why they are arrested? What is the ejection fraction? And then does the right ventricle look bigger than the left ventricle? Let's start with effusion. So as we saw in a normal heart, there should be no fluid around the heart that you can appreciate, or maybe just trace. But as we can see here, this is a considerable amount of fluid around this heart. And the heart is looking stressed out. Look at this right ventricle. It's stressing out. Fluid looks hypoechoic or anechoic. It surrounds the heart. Sometimes it could be regional. There could be some fluid on one part or not the other part. Now, we are really most concerned for a pericardial effusion when it's leading to hemodynamic compromise. For example, if somebody comes in and has a blood pressure of 70/30, heart rate of 140, and is breathing very fast and looks very uncomfortable, you look and you do a cardiac scan and you see this, we're concerned for a tamponade. That could be the reason why they are in distress, and that is why we are concerned for effusions. Now, pericardial tamponade and how to look at the echocardiographic signs is a little bit beyond this basic talk, and we can probably do that at another date. But just a quick thing to look at: if it looks like there's like a small man jumping on this right ventricle, that means the right ventricle is stressed out. That's a sign for pericardial tamponade, particularly. And then if they are hypotensive, that just goes to support your diagnosis. Now, different types of fluid can look like they're around the heart. So how does one tell is this a pericardial effusion or is this a pleural effusion? So remember that I said in your personal lung axis view, you want to always get the descending aorta, and this is why. When the fluid tracks anterior or in front of the descending aorta, that is a pericardial effusion. When the fluid tracks behind or posterior to the descending aorta, that is a pleural effusion. Again, I'll say it one more time. We get our personal lung axis view. If the fluid tracks in front or anterior to the descending aorta, that's a pericardial effusion. If the fluid tracks behind or posterior to the descending aorta, that is a pleural effusion. So can somebody help me out here? This very top, is this a pericardial effusion or is this a pleural effusion? What do you think? When we look here, the fluid is actually tracking behind the descending aorta. It's not going in front of it. Compared to
someone
this
in that chat. Someone in that chat posted pleural effusion. We have some answers in the chat.
Exactly. This is a pleural effusion because the fluid is tracking behind. See how it stops here? It doesn't go anterior or in front of the descending aorta. While here, we see the fluid goes in front of the descending aorta. So this here is a pericardial effusion, and you're right in saying this is a pleural effusion. Great job. Next thing is ejection fraction. So when we do ejection fraction in the ED, it's going to be qualitative analysis. That means I'm looking at the heart and I'm seeing, is the EF good? Is it bad, or is it ugly, right? Now, there's other ways you can do this, like, endpoint septal separation that we can discuss at another time. But for today, let's just discuss basic echo. Looking at this, can you tell if this is good and this is bad? So look here. I will tell you, and I'll just start this off by saying, this is a normal EF, good EF. How do I know? I'm looking at the wall of the left ventricle. It's coming together nicely. If this individual doesn't have any mitral valve abnormality, then the mitral valve should be touching the septum here, which it is doing. This looks good, good EF. What about this? Now, I can tell you the walls of this left ventricle are barely moving. The mitral valve is not moving at all. Look at the aortic valve is doing all the work here. So this is poor EF. And this is what I do in when I go for my shifts. I just look and I see this is good and this is poor. And when you're busy or when you're making that split second decision, that's what you need to actually appreciate. What about here? Again, I told you that this is a parasternal short axis view, right? Because we can see that the heart is cut in cross section at the level of the papillaries. We have the septum. We see part of the right ventricle. We are looking at squeeze. Okay, this is the left ventricle. So when I look at this one here, if I put this in the center, see how all the walls of that left ventricle is squeezing towards the center and is doing so rigorously. Compared to here, look at the squeeze, barely doing anything. So this is normal or good, and this is poor. Okay. The next thing is equality. So when we think about equality, as I said, we are concerned for any signs of right ventricular strain. What that means is, as I said, the right ventricle should be less than the size of the left ventricle. It should be about 2/3, so 0.6 to 1. Upper limit of normal is 1 to 1. So let's say they're about the same size. That's the highest limit. Now, if the right ventricle is bigger than the left ventricle, I'm concerned for right heart strain. But remember, it's all going to be depending on the right clinical context. So what happens whenever I see an echo, and this should just be a rule of thumb for all of us who practice, you want to go back and check, is this echo finding new or is this old? Let's say an 80-year-old patient comes in, respiratory distress, they are tachypnic to the 40s, oxygenation is 80%, blood pressure is like 100 over like 60. You look and you see that the right heart is large. They've not had any echoes in the past, and they don't have any history of heart issues. I'm going to be concerned for a PE. But let's say somebody else comes in with a history of COPD. They are huffing, they are puffing, they're in respiratory distress. You look and you see that the right heart is large. Now, the right heart could be large because of they have pulmonary hypertension from their COPD. So that could be chronic, and that could maybe not be an acute finding. So that's why it's always important to glean and to get the patient's history and consider the context. Other things that could increase, if it's acute and there's right heart strain, I'm concerned for pulmonary embolism, right? That's the number one thing that we are going to be concerned for. But patients who have any kind of pulmonary disease like asthma, COPD, pulmonary hypertension, any right heart failure, right? Their right ventricle could also be large. So I just want us to appreciate that as we move on. But in this case, let's just consider that we are looking at a patient who has never had heart issues in the past, prior echoes, they've never had an echo, or the echoes have been normal. And then we see that the right heart is huge. And they're in respiratory distress, they are hypoxic. Then I'm going to be concerned for a PE. So this is normal. This is the left ventricle. So this is our apical 4 chamber view. Left ventricle, right ventricle. We see here they're about the same size. As I said, it could be upper limit of normal. They could be 1 to 1, but it should, most times it's less than the left ventricle. This is normal. What about this? We see here the right ventricle looks considerably large. The left ventricle looks small. We see the right atrium also looks large. So this might be in a patient who's had chronic disease, either from pulmonary hypertension or something else. But we can see that this is abnormal. This looks considerably bigger than the left ventricle. Somebody help me out here. I want you to, number one, tell us, either from the chart or just speak, how do we differentiate the right heart from the left heart? And what is normal and what is abnormal here? Feel free to speak, or I'll look at the chat as well. Anyone? Exactly. There's a moderator band on the right, yes. When you say squeeze, what do you mean? Farida, you said the squeezing. I see the moderator band, yes. Exactly. The squeeze for the right side is longitudinal, or up and then down. The squeeze for the left side is in and then outwards. So thank you so much for responding. So this is the right side of the heart. We see the moderator band here, and this is the right side. We can appreciate the moderator band here. We can also tell that the tricuspid valve is more towards the apex, so it's apically displaced. And we see that the squeeze of the right side is up and then down. The squeeze for the left side is in and out. Okay, that's the first part of the question. What side here is normal and what side here is abnormal, and why? What side is abnormal and what side is normal? Exactly. Thank you. Exactly. Thank you for the response here. So we can tell this is the abnormal side. Why is it abnormal? We already identified this as the right side because we have the moderator band that comes across here. We see that the tricuspid valve is apically displaced, right? And then here, this right ventricle just looks large, much larger than the left side. So this is abnormal. This is normal, and we know that this is the right side again because we see the moderator band here. We're actually able to appreciate squeeze, and we see the squeeze is more up and then down, and we see the tricuspid valve is apically displaced. Great job. Now this is our short axis view, a personal short axis view. And if you're concerned for right heart strain, as I said, one view is no view. So if you see something on one view, confirm it on a second view, and let that be your practice always. So if I see right heart strain on that apical 4 chamber view, my next job is to go to a personal long axis view. What I will see, again, this is the septum. We see part of the right heart here. This is the left ventricle. When there is strain, when that right heart is big, it's going through stress, something is causing the pressure there to somehow increase, the septum is going to flatten, okay? And this is what we call a D sign. And it is a sign of right heart strain, okay? So in summary, We've gone through basic cardiac echo. Yes, we are done. We talked about our tool. Our tool is the cardiac probe. It's a low frequency probe. It has a small footprint, so it's able to go in between ribs. Okay. And again, it's a low frequency probe, so it allows us to see deep things like the heart. We spoke about the 4 views of the heart. The parietal long axis view. Remember, when we do that view, we are pointing the probe marker towards the patient's left hip. That's the EM way. And we want to be in that 2nd to 4th parasternal space on the left side. For the parietal short axis view, we're going to just rotate the probe 90 degrees. Probe marker is going to point towards the patient's right hip. We'll be able to see the heart in cross section, and we want to get at the level of the papillaries. Both of these views, the long axis and the short axis view, tells us about the EF, tells us about just the general function of the heart. With the long axis view, you want to make sure that you are seeing that descending aorta. If there's fluid that tracks in front of the descending aorta, we're concerned for a pericardial effusion. If the fluid tracks behind it, it's more like a pleural effusion. For that short axis, we talked about if that septum is flat, it could be a sign of right heart strain. It's also a good view to look and see what the function of the heart is in terms of EF. We spoke about the subxiphoid view, right? So we're going in that xiphoid process. The liver is going to serve as our acoustic window. It's going to be the first thing that we are going to actually see. And it's a good view to look at general function of the heart too, but to appreciate the size of the right ventricle compared to the left ventricle. We also spoke about the apical 4 chamber view. So in men, we're going inferior and lateral to the nipple. In women, we're going in that inframammary crease. Probe marker is going to point towards the patient's right. It's a good view to look at equality. When we're comparing the size of the right ventricle to the left ventricle. We spoke about the different ways that we can differentiate the right from the left. So remember, the right side has the moderator band. The right side, the tricuspid valve is more apically displaced. The right side, the squeeze is more up and down or longitudinal compared to the left side. The left side, the descending aorta is going to be on that side. The squeeze is more inwards and outwards. We spoke about the 3 E's. For anybody that comes in with a cardiac arrest, syncope, unexplained hypotension, chest pain, shortness of breath, when we do a cardiac echo, these are the 3 questions that we want to ask. Is there a pericardial effusion? What is the ejection fraction? And what is the EF? Oh no, I'm sorry. And what is the right side of the heart compared to the left side? It should be smaller or at most 1:1. If it's bigger, it's a concern for right heart strain. And if it is acute, then you're concerned for a pulmonary embolism. Now, it could also be chronic, particularly in patients who have a history of pulmonary disease. I want to thank you for your attention. Thank you to AFEM for having me. We hope to have more of these talks in the future. If you have any questions, feel free to email me. This is also my Twitter, or X now, as we call it. And I'm going to stop sharing my screen so that you can be able to ask your questions. Feel free to unmute to ask your questions. Thank you.
Thank you so much, Oni. It's now question time. So if anyone has a question to ask, please feel free to raise your hand and unmute and ask. For now, we shall start with the question that is on the chat. Okay. I will just mute that person. They're not asking a question. So we can start by answering a question on the chat. Someone asked that, is the descending aorta always on the left side?
Yes.
That's the first question.
Yes, it is always on the left side. And that's how you know what the left side is. So it's one of the identifying features of the left side. Yes.
Great. Thank you so much. Is there anyone who has a question that they need to ask? Please raise your hand and then unmute. In the meantime, please make sure you also register. There is a Google form that I've just posted on the chat. We would like to receive your email addresses and then share the recording link as well as the lecture slides. Other than that, I also have a question, Oni. Could you just briefly comment on the role of cardiac ultrasound when it comes to CPR, resuscitation, and deciding to terminate? Thank you.
Yes, and hopefully we can do a talk about that. But in my practice, I use it all the time for cardiac arrest. So if somebody just comes in and let's say, they had a witnessed or maybe unwitnessed arrest, and we will usually do the cardiac ultrasound during the pulse check. So you never want to interrupt a CPR, right? So you want to keep on going. But during the pulse check, while we are checking the pulse, then somebody else is putting the cardiac probe on the patient's chest, and then we are trying to see. What we're trying to see is if there is any heart function, if there is any squeeze. A lot of times, you will see cardiac standstill. Let's say we've run the arrest for a considerable amount of time, 20 minutes, 30 minutes. Then once we've seen cardiac standstill a couple of times, we will terminate that resuscitation, particularly past the 25 or 30 minute mark. Now, and also sometimes now studies have shown that cardiac ultrasound, you may actually be able to appreciate like fibrillation, where you just see the heart is fibrillating, and that might not even be appreciable on the monitor. So if we see that fibrillation, then sometimes we will also shock, because that's something that we're able to appreciate on the ultrasound that we're not able to appreciate on our EKG leads or on the monitor. So yes, we use it a lot. And now what most people are using now, which is the future, is TEE, so transesophageal echo, which is what the cardiologist and the anesthesiologist use, where they put the ultrasound through the patient's mouth, goes in through the esophagus, and it just gives you like a better view. And of course, it can remain in the patient's esophagus during CPR. The patient will need to be intubated, but this is for cardiac arrest. So yes, we use it to determine if there's standstill. We use it to determine if there's any type of cardiac activity. We use it to determine if there's any type of fibrillation that is going to encourage us to maybe give electricity. And the future is now TEE, or transesophageal echo.
Dr. Faith.
I'm sorry, Sheba has a question. Sheba, if you want to unmute yourself and ask your question.
Yeah, so my question was, the absence of a phased array probe, what other probe can you use for the cardiac ultrasound? And how different will the views we have discussed be?
Yes, so I have run into this issue a couple of times. Your phased array probe is the best probe for this because it has this small footprint. So you are able to go in between ribs. The problem with the curvilinear probe is that the footprint is very large. So you might be able to see the heart, but you might be getting ribs. So we use for the curvilinear probe, the probe that has the long footprint, it will be good to get a subxiphoid view, because you can, go, you are going in that subxiphoid place, right? And you are going to get the liver. So you can use that for that view. And you may be able, I've used it a couple of times to appreciate a parasternal long axis view, but I will tell you it's difficult because of ribs. It's not impossible, but you can definitely do it, but it's more challenging. Idowu Emmanuel raised his hand. Yes, if you want to unmute yourself. But hope I answered the last question by Sheba.
Thank you very much, Dr. Onyinyechi. Nice presentation, I must say. I just want to make a few contributions to some of the submissions that you had made earlier. We should factor in variations, anatomical variations in the interpretations of basic ultrasounds, because there are a number of physiological variations or pathological variations in some of those patients, so that will not, which can be a pitfall to interpretations. Then point of care, yes, we should marry ECGs, shortness of breath panels, cardiac markers into the holistic interpretations of some of the things that we may pick when we are doing our point of care ultrasound. Then lastly, I will want to also say that in the event that there are no other like phased array probe, there are a kind of substitutions that someone can do with some of the other probes, at least for cardiac examination, in the event that maybe the individual is in a low resource environment as it is. Thank you very, very much for the presentation. Nice one. Excellent. Thank you.
Thank you. Thank you. Thank you so much for the contributions. Okay, so somebody just asked in the chat, said a comment, another reason why you can use ultrasound in cardiac arrest is to rule out a cardiac tamponade as a potential cause of cardiac arrest, which is part of the reversible causes of the H's and C's. Exactly. Tamponade is part of the H's and C's. So that's why we do this, and that's why this is important, because you could potentially save a life if you're able to acknowledge this on your ultrasound. What happens if you notice appreciable cardiac activity during a CPR? You check if there is a pulse and you keep on going. So if I see cardiac activity on the ultrasound, then we continue resuscitation. If we don't have a pulse, we continue to give epi. But then if we see cardiac activity, first thing that we do, we check for a pulse, because if there is cardiac activity, there could be a pulse. If there's no pulse, we continue. It's just the way it is. And of course, if it's, we have to define what cardiac activity is, right? The mitral valves fluttering is not cardiac activity. We are looking for ventricular squeeze. So if we are seeing that squeeze, then we keep on going. What you will diagnose PA? If we have a pulse, then we are good. If we don't have a pulse, we keep on, we continue with our CPR. Now, if it's 45 minutes, you will not, I've never seen a situation where we've had cardiac activity for 45 minutes and we don't have a pulse. Like, something is going to happen. Either the heart is just going to stop, or we are going to have a pulse. So one or the other is going to happen. The heart just can't keep on going without any type of feedback. You're either going to have a pulse, or then you don't, and the heart just stops. Kindly comment on the use of cardiac ultrasound in shock. Yes, so there's the rush examination. We can do a lecture for that in the future. That's kind of like a shock exam where we look for DVTs and we look at the aorta and IVC. So we can do that at a later time. But for IVC, so when we want to, and we can also do an IVC talk. So these are all these are all future lectures that we can do. But for the best IVC, so for the best IVC view, in that sub-xiphoid view, so I'm just going to use my hand here, if you can see. For the so when you're in that sub-xiphoid view, so remember that the probe marker is pointing towards the patient's right. Then what I will do, turn the probe marker towards the patient's head, move anteriorly, you find left, you find right, you will see the IVC. The IVC is going to empty into the right atrium. Just remember, underneath the IVC is the aorta. So you don't want to confuse the aorta and the IVC. But it's the IVC because you see liver that is going on top and below the IVC. For the aorta, you will not see that. For the aorta, you will see the spine. So it will just be bright white and then the shadowing. So again, in your sub-xiphoid view, that's the best view to look for the IVC. Turn the probe marker towards the patient's head, fan left, fan right, you will see the IVC. Great questions.
Okay. We have a hand up from Laura. Laura's iPad. Please unmute and ask your question.
Hello, I'm Laura. I'm a resident in emergency medicine in Mozambique. So I would like to ask if you use, if you do a lot of central vein catheter ultrasound guided in your hospital.
Yes.
Thank you.
Yeah, no, thank you for the question. Actually, that is the standard of care. We don't do blinds. We always use an ultrasound, particularly for IJs. If we're doing any intrajugular access, we always use ultrasound. If we're doing femoral access, we always use ultrasound. Now, for the subclavian, people still do blind subclavians. But if we're going through the IJ or even FEM, it will be ultrasound guided. And we can also do a talk on ultrasound guided IV access in a future talk too.
Okay, I've taken note of all the things we need to organize webinars for. And so we shall try to schedule them for next year. I think there's one more question that just came into the chat.
Question about, yes, somebody puts a question about controversy about continuing a CPR if there's PE, if there's some kind of cardiac activity. So that's why we have to figure out what cardiac activity is. If the mitral valve is just fluttering, that's not cardiac activity, right? If there's fibrillation, remember you can shock. But when I'm saying a cardiac activity, I'm looking for like a squeeze. I'm looking for some type of EF. So when I see that, that is going to kind of guide me. Now, there is controversy that with all the epinephrine that you give the patient, there could just be residual, like, things going on. So it is going to be, I think, a clinical decision at that point. And I think, for instance, let's say you've been working on the patient for 45 minutes or, close to an hour, and you see something, but you're not sure. And then at that point, I would call it, particularly if there is no pulse. If there hasn't been a pulse for like a long amount of time, because with good cardiac activity, you should be able to it should either get better or it should get worse. And then at a certain point, that's going to be a clinical decision. So yes, there's a lot of controversy about that. I think the most helpful thing it does for us when we're doing resuscitation is when we see cardiac standstill, right? When we see cardiac standstill, that's okay. It is done. We stop, particularly if we've been going for 30 minutes. If we see cardiac activity, we will continue, but you have to really assess and figure out, is this a perfusable rhythm, right? Is this something that is going to bring back ROSC? So that, again, is going to be a clinical decision. But yes, there is some controversy about that. So thanks for stating that.
Okay. Is there any final question before we summarize and close? Okay, I don't see any hands. So I'd just like to give a vote of thanks. Thank you so much, Oni, for making the time and preparing this wonderful presentation, and also offering to do more lectures for us in the coming year. And we shall definitely organize for that. Before we close, I would also like to appreciate the AFM team. I've seen Dr. Melinda has joined us, as well as Dr. Membeo Sultan. Thank you so much for joining. We also have Dr. Simon Tinosime, who has joined us. So thank you to the AFM team for the support. And thank you to the Delta technical team as well. We have the whole team with us today. Afriye, we have Shiva, Kof, we have basically the whole team. So thank you to everyone who made this happen. And we shall look forward to having more of these next year.
And thank you so much for having me. And thank you for all of the questions, the suggestions, the comments, the controversies too, with everything. Happy to give more lectures in the future. So thank you.
All right. I will now end the meeting. Thank you all and have a lovely evening.
Thank you.
Or morning. Okay, bye.